If only having a baby were as easy as having a stork drop one off at your doorstep. By now we all know that's not how we came to be. Sometimes making a baby is easy. Sometimes it is very hard. Hopefully this little show will help illustrate just one way technology has enabled conception for those who struggle. This is Jane. This is John. They're in their 30s, so when they decided they wanted to have a family, they talked to their doctor about what they should do if it isn't working out for them. Their doctor told them to try for a year. If after a year they never conceive, they should go to a reproductive endocrinologist. Unfortunately for Jane and John, a year has passed and they haven't conceived. Their lives are about to revolve around their desire to have a baby. Jane and John have filled out extensive medical history questionnaires that were sent to their house. Some questions they had to answer were, do you have a history of pregnancies, miscarriages, and live births? What is your sexual history? What type of contraception do you use? Do you have PMS? What is your male partner's sexual history? Has your male partner had any infections, surgeries, or hernias? What health conditions do you have, or have you had since you were born? What is your lifestyle like? Do you exercise? Are you stressed? Do you drink a lot of caffeine? A lot of alcohol? Do you smoke? How is your daily nutrition? What medications do you take, prescribed, unprescribed, or over the counter? What medication does your male partner take? These questions are going to help pinpoint where the fertility issue is. There are many causes of infertility. For women, this can be because of damage to the fallopian tubes, ovulatory problems, endometriosis, or conditions affecting the uterus. Age. Female fertility declines sharply after the age of 35. Polycystic ovary syndrome. Lifestyle factors such as stress, being overweight or underweight, and smoking. For men, conditions that may result in infertility are low sperm count or quality, problems getting an erection, problems with the tubes carrying sperm, problems ejaculating, genetic problems, diabetes, lifestyle factors such as being overweight, or having a job that involves contact with chemicals or radiation. At their appointment, John has tests. These include a general physical exam, including examination of his genitals. He has some specific fertility tests. Semen analysis, where a lab will analyze John's semen. Hormone testing, where he has a blood test to determine the level of testosterone and other male hormones. And genetic testing. The genetic testing may be done to determine whether there's a genetic defect causing infertility. The clinic also informs John that he may need tests such as a testicular biopsy. In select cases, a testicular biopsy may be performed to identify abnormalities contributing to infertility and to retrieve sperm to use with assisted reproductive techniques such as IVF. Imaging. In certain situations, imaging studies such as brain MRI, bone mineral density scan, transrectal or scrotal ultrasound, or a test of the vas deferens vasography may be performed. In rare cases, other tests to evaluate the quality of the sperm may be performed, such as evaluating a semen specimen for abnormalities. Jane is going to have to undergo tests as well. These include a general physical exam, including a regular gynecological exam. She is told she will have to do some specific fertility tests, including ovulation testing, where a blood test will measure hormone levels to determine whether she's ovulating, hysterosalpingography, which will evaluate the condition of her uterus. X-ray contrast is injected into her uterus, and an X-ray is taken to determine if the cavity is normal and ensures the fluid spills out of her fallopian tubes. Ovarian reserve testing. This testing helps determine the quality and quantity of the eggs available for ovulation. This approach often begins with hormone testing early in the menstrual cycle. Jane may also need other tests like other hormone testing. Other hormone tests check levels of ovulatory hormones as well as pituitary hormones that control reproductive processes. Imaging tests. Pelvic ultrasound looks for a uterine or fallopian tube disease. Sometimes a hysterosonography is used to see details inside the uterus that are not seen on a regular ultrasound. This all takes time. Some time passes to allow for these tests to take place and for the results to be gathered. Jane and John have been called by the doctor. The results are in. The doctor informs them that there is an issue that will make natural conception very difficult for them. John has low sperm motility. Jane and John have a lot of material to read. They have options, but they know that IVF is very successful in couples where male infertility is the issue. By reading the information on IVF, they are made aware of the pros and cons. Some of them apply to them, and some of them are general. The pros are, it gives infertile couples the opportunity to have children. It helps women who have blocked or damaged fallopian tubes. IVF is the only treatment available for women with blocked fallopian tubes because it does not require them to be open. Intrauterine insemination requires them to be open. It helps women who are in their later 30s increase probability of pregnancy. It can assist single women or same-sex couples. Multiple births are possible. For those couples who want multiple babies, there's a good chance of that happening. It can reduce the risk of genetic disorders passed down to embryo by screening the embryo before implantation. It also allows preservation of eggs for future use. The cons are, there's a high failure risk. Only about 25 to 30% of IVF cycles result in a live birth. The success rates depend on the age of the female, quality of the egg, sperm, and uterus. There's a risk of multiple births. Multiple births increase with IVF because more than one embryo is often implanted. Some couples may not be ready for that. Multiple births also increase a risk of birth defects. It's a very costly procedure. It costs about $10,000 to $20,000. There's also an additional cost of tests, medicine, and consultations. There's also a risk of ectopic pregnancy, which is a pregnancy outside of the uterus. Jane and John are in a financial position to spend upwards of $10,000 on IVF, and they decide that this is their best option to have the family they so desire. The process of finding out what their issue was regarding infertility is now only the beginning. IVF is a very intense process and requires diligence in order for it to work. The cycle before her IVF treatment is scheduled, Jane is asked to track her ovulation. She buys an ovulation predictor kit because she wants to use the kits along with charting her basal body temperature, which is an indicator of ovulation. Jane is told that she needs to tell her doctor immediately when she detects ovulation. When Jane starts ovulating, she is put on a GnRH antagonist, ganirelix, which she must inject. The drugs will allow her doctor to have complete control over ovulation. The first official day of Jane's treatment cycle is the day she starts menstruating. On the second day of her period, she goes for blood work and a transvaginal ultrasound. These first day ultrasounds and blood work are Jane's baseline blood work and baseline ultrasound. In the blood work, the doctor will be looking at Jane's estrogen levels, specifically estradiol. This is to make sure Jane's ovaries are sleeping. That's the intended effect of the GnRH antagonist. The ultrasound is to check the size of her ovaries. Everything looks okay for Jane. So they move on to the next step, which is ovarian stimulation with fertility drugs. This means Jane is going to have anywhere from 1 to 4 shots every day for about a week to 10 days. Jane is well versed in injections though from the GnRH antagonist. During ovarian stimulation, Jane's doctor monitors the growth and development of the follicles. For Jane, this means blood work and ultrasounds every few days. Jane's doctor will be monitoring her estradiol levels. During the ultrasounds, her doctor will monitor the oocyte growth. Once Jane's largest follicle is 16 to 18 millimeters in size, Jane will be going in to her clinic daily. The next step in IVF treatment is triggering the oocytes to go through the last stage of maturation. The eggs must complete their growth and development before they can be retrieved. This last growth is triggered by human chorionic gonadotropin, or HCG. Brand names for this include Ovidrel, Novorel, and Pregnyl. Timing this shot is vital. If Jane takes it too early, her eggs won't have matured enough, and if she's too late, they may be too old, and they won't fertilize properly. The daily ultrasounds at the end of this last step are meant to time this trigger shot just right. Usually, the HCG injection is given when 4 or more follicles have grown to be 18 to 20 millimeters in size and estradiol levels are greater than 2,000 pg per milliliter. This shot is typically a one-time injection. Jane's doctor will likely give her an exact hour to do this shot. This is very important. About 34 to 36 hours after the HCG shot, the egg retrieval will take place. Before the retrieval, an anesthesiologist gives Jane some intravenous medication to make sure the procedure is not painful. Jane will also have a light sedative to allow her to sleep through the entire thing. This is not like general anesthesia, so side effects are less likely to occur. While Jane is sleeping, the doctor is going to use a transvaginal ultrasound to guide a needle through the back wall of her vagina up to her ovaries. The needle will be used to aspirate the follicle, which means that the fluid and oocyte is going to be sucked into the needle from the follicle. This means one oocyte from each follicle will be obtained. They will then be transferred to the lab for fertilization. Jane was told before the retrieval that there is a 95% chance they'll retrieve at least one oocyte, but that usually they manage to get between 8 and 15. Jane doesn't have fertility issues, so they can see from the ultrasound they'll be able to get more than one. Jane is going to stay for a few hours after her retrieval to make sure she's alright. She does have a little spotting and some cramps, but that is normal, and she needs to expect it. This will only last for about a day. She is also supposed to watch for symptoms of ovarian hyperstimulation syndrome, which is when the ovaries become swollen and painful. This is a side effect in 10% of patients from the fertility drugs. Jane needs to look out for mild to moderate abdominal pain, bloating, nausea, vomiting, diarrhea, tenderness around her ovaries, and a sudden weight increase of more than 6 pounds. While Jane's at home recovering from the retrieval, the follicles that were aspirated will be searched for oocytes, or eggs. Not every follicle will contain an oocyte. Once the oocytes are found, they'll be evaluated by the embryologist. Fertilization of the oocytes must happen within 12 to 24 hours. John gave a semen sample while Jane was having her retrieval procedure. Once the semen sample is ready, it'll be put through a special washing process which separates the sperm from the other components in semen. In the case of John's male infertility, ICSI will be used to fertilize the eggs, instead of simply placing them in a culture dish. With ICSI, the embryologist will choose a healthy-looking sperm and inseminate the oocyte with the sperm using a special thin needle. About 3 to 5 days after the retrieval, the fertilized eggs will be transferred. During the embryo transfer, a thin tube or catheter will be passed through Jane's cervix. Through the catheter, they transfer the embryos along with a small amount of fluid. Jane is told she may experience very light cramping, but nothing more than that. Jane and John always wanted a big family, so they have a few embryos transferred. They know that increases the chance of having twins, triplets, or more, but they accept that risk to increase the chance of ensuring they have at least one viable embryo. After the transfer, Jane lies down for a couple hours before she can head home. Jane started giving herself progesterone supplements after she had her retrieval. More needles! Besides the progesterone, there really isn't much going on for the week or so. Jane and John keep busy, but it feels like time is taking forever to pass. 9 days after the transfer, Jane has blood taken to do a serum pregnancy test. Jane's pregnancy test is positive. This is not the case for everyone. Some people have to try a few times before they are pregnant. John and Jane are parents!